Hello, welcome to today's question and answer hour. I'm Dr. John Kruse, and I'll be trying to answer questions about ADHD, about the videos I released last week, and about mental health in general. So a couple housekeeping announcements. One is that everything I say here is for general informational purposes only. It's not meant to be specific recommendations since I haven't done an evaluation on any of you. Two is that next week, which will be the 30th, I'll be traveling, so I won't be around. So I will be back 2 weeks from now, which is January 7th. And so I think those are the past announcements. So the two videos that were released this week, one was a new one on normal brain aging, and the second one was on where Max had edited the sound on a generalized P factor uniting all of psychopathology. So I'll summarize each of those briefly. Then there is a question from the Reddit I'll try to answer, and then I see Sean and maybe others will already have questions out there. So the general P factor is the concept that underlying all psychiatric conditions, everything in the DSM, where we have more than 220 different diseases or conditions right now, there's some statistical research trying to look at central factors that suggest there is one unifying factor underlying all psychopathology. There's some genetic evidence that most of our psychiatric conditions are polygenic, affected by many, many, many different genes, and that many of these genes are shared. But the view of some other statisticians is that this P factor is an artifact, and it's just a measure of impairment that you need to have a psychiatric condition, and it's not really revealing any underlying structure. My statistic ability isn't deep enough to sort out which of these are true or not, but ongoing research will hopefully get us a clearer answer. So the second talk was on brain aging, and it is tricky sorting out what's normal aging from dementia and other conditions, particularly since dementia anatomically, Alzheimer's dementia in most individuals seems to be starting 20, 30, or even more years before most signs are visible, but it's possible that some people are having less severe, more episodic signs, and these people are being lumped as normal aging when they're really pre-dementia. Given that looking at big populations of people, we can see that while certain what are called crystallized intelligence, and that's things like vocabulary, sets of facts, understanding how the world works, remains pretty consistent. Some of those, like vocabulary, actually improve or increase over time. Other factors that are considered fluid intelligence, and many of these include some of the same executive functions that are affected by ADHD, do seem to decline starting in late 20s or early 30s, declining at a fairly steady rate until maybe in the mid-60s. There's a more significant increase in drop-off. Some of this is reflected in patterns of the wiring of the brain in different developmental stages. But the important thing is that if you look at the DSM-9 inattentive symptoms for ADHD, and there's 4 impulsive symptoms as well, all 13 of those symptoms for ADHD are actually aligned with executive changes associated with completely normal aging. So with normal aging, I think it's valid to say human brains are looking slightly more ADHD-like. So I can talk more about either of those topics. I see there's 2 questions waiting, but I will get to one question that Max had forwarded from the Reddit page. And I don't know who actually asked it, and I'm paraphrasing, but the question in one of my videos, I said that there's a distinction between ADHD and autism, whereby although someone with ADHD may be, and specifically in terms of getting involved in hobbies or activities. So with ADHD, there may be a tendency to do deep dives down rabbit holes and get lost from what the main original objective was, but these are sort of deep and meaningful explorations. I shouldn't have used the word meaningful, but whereas in autism, and this isn't just my description, many of the hobbies or interests tend to be superficial or abstract and not really connected with the human element of what that hobby is. And a common example, and this is actually not just commonly cited, it is a moderately common, is memorizing timetables for a bus system or a transit system or underground system without having any awareness of where these stops are, what the stops mean, what different people or activities might occur at those locations. So it's, again, or people with obsessions about, or I should say obsessive interest in airplanes, but they go to an airfield and record the registration number on the underside of the wings of the plane without, and spend hours doing that without much consideration of what the planes are doing or different even models of planes, except again in the abstract sense. So the person was questioning, aren't the activities someone does with ADHD when they're going down a rabbit hole, isn't that essentially superficial and meaningless? And I would say, even if it's not germane to the original search, the search isn't so superficial, means that the investigation is remaining on a certain realm of information that is paying attention to details, paying attention to numbers, and is devoid of the human context. And to the extent, I mean, I think the definition of a central part of autism is difficulty processing or comprehending some of the social realm of not getting. So it's not being shy, it's not having an aversion to being scrutinized in public or being awkward or uncomfortable. I mean, the person might be awkward, but usually their awkwardness is without much internal sense of awkwardness. They're just doing what they think is logical and reasonable. So again, and I think if someone doesn't have some element of that social deficit, to me, the autism label doesn't make a lot of sense. But I know increasingly it's a label that's employed for a lot of things, including people who have ADHD and no core autistic symptoms or social anxiety and aren't really displaying autism. Now, you can certainly have ADHD or social anxiety and have autism, but so I hope, again, I hope I've clarified that distinction or justified that distinction. And again, it's not just my definitions. These are assertions and claims made by other people who study groups of people with autism extensively. So again, happy to try to explain that more if that didn't cover it, but I'm going to move on to Sean's question. So Sean says, as diagnosed with inattentive ADHD and anhedonia, Adderall helps, but he needs to take many small doses, 2.5, 3 to 5 times a day to avoid spikes, and still gets an evening crash when it wears off. XR doesn't work well. Thoughts on more stable options? So one option, or one thing to consider, is with the extended release form of Adderall, different manufacturers, and in the US, there's at least 6 or 8 different companies that make different brands, different generic formulations of Adderall XR. It has to contain the real dextro and levoamphetamine combination. It has to have a slow release profile, but there is some deviation or slop allowed. And the thing to remember with stimulants, it's not just the absolute concentration of the drug at the receptor, it's the change in concentration as well that seems to determine how they work. So a drug that's going in a little faster or a little slower may feel substantially different, even though it's the same molecule. So one would be one cheap option would be, and at least in the US, the prescription bottle for a generic does have to include which brand maker, which company, whether it's Abbott, whether it's Teva, someone else made it. It's usually in really tiny print, but it should be there. So one, just seeing if a different maker of XR works better. The second thing that I think many people would jump to would be Vyvanse. So Vyvanse is the same dextroamphetamine. It's the same major component within Adderall. And not for everyone, but for many, many people, it just works more consistently, more smoothly. So the timing of delivery throughout the day. And in general, the slow release formulations, which were all initially designed just to prevent the need for kids going to the nurse and having to dose multiple times a day. So ideally, they could be dosed at home before they went to school. Sort of a side effect that wasn't directly planned into it is that in general, the extended release forms have much less withdrawal, crashing either in focus or energy or mood. So the slower entry into the body usually equates with a slower or more gradual leaving of the body. I mean, if Vyvanse doesn't work, I mean, it may be worth trying something on the methylphenidate approach. And again, Concerta is the one option that I've had more patients feel works well for them. So those are two different ways to go. I mean, there's some amount of research that suggests taking a non-stimulant like Qelbree, viloxazine, or atomoxetine Strattera may help provide more constant coverage, and then you may need a smaller dose of a stimulant on top of that, and that may prevent fluctuations. So hopefully that's things to, again, those are not specific recommendations, those are ideas to discuss with your provider. So Max is forwarding another Reddit question with a follow-up for today. Could I talk about when it's autism and ADHD together, especially when it's, for example, someone with severe autism and ADHD? So again, you certainly can have the two together. And in fact, having autism makes you more likely than the general population to have ADHD, and having ADHD makes you more likely to have autism. I mean, if the question is jumping back to sort of hobbies and interests, if both are going on together, I'm not sure that it's important to label or designate, oh, my interest in timetables for the train station, or my interest in trying to photograph as many different trees within San Francisco as I can. I mean, whether that comes from ADHD or whether that comes from autism, I don't see a particular value to trying to ascribe where the hobby or activity came from. I would say if it feels like it's a waste of time, then again, and you want to put in safeguards against that, that would be one thing. But again, I don't know that that even requires designating which condition it came from. So if I'm missing part of the question and you're listening in, I guess I may need to follow up later, or maybe you'll chime in. Maybe you're watching now. So again, I'm having trouble reading. I'll just leave these on. Incognito C10. I did an ADHD assessment recently. The outcome was that I have ADHD, but because of suicidal thoughts in the past and high blood pressure, the doctor recommended Strattera and lamotrigine. But I struggle most with motivation and finishing tasks. So I'm going to jump back because it just reminded me that Sean's question also mentioned anhedonia as part of inattentive ADHD. And there's some interesting data, mostly focused in the depression world, but there is a strong correlation with brain inflammation being particularly tied in with anhedonia, lack of motivation, or anhedonia is more lack of being able to enjoy activities, particularly ones that formerly or theoretically should be enjoyable to you. So jumping back down to Incognito's question, so are suicidal thoughts a reason not to be on stimulants or force one medication over another? So I would say absolutely not, and that's almost inanely stupid. There's robust evidence, one, that ADHD itself is associated not just with suicidal thoughts, but with the completion of suicide, and two, that it's not just depression resulting from or going along with ADHD, but that probably the impulsivity of ADHD substantially increases the risk for suicidal action in individuals with it. And three, there are multiple studies showing that, and it's particularly stimulants that have been looked at, that treatment with stimulants reduces both suicidal thoughts and actions in those with ADHD. There is, I believe, some evidence indicating that Strattera may have, atomoxetine, have some of that suicidal reduction in thoughts and activities, but my recollection is at least one study showed that it was much less helpful in that regard than were the stimulants. It could have been an issue of underdosing with that. Lamotrigine in the US is approved for depression in the setting of bipolar disorder. It has not been approved by the FDA for depression outside of bipolar disorder. Whether or not it works well in that condition, there's fairly limited data suggesting it. I've certainly used it for depression, and partly when other things don't work. Again, it is approved for bipolarity, but it does seem less effective for the manic states than less effective than almost any other mood stabilizer for manic states. And therefore, I mean, it could be the doctors thinking it's helpful for mood instability and fluctuations and emotional dysregulation. I'd say we have very limited data on that. So there may well be very good reasons the doctor chose this combination, and rather than going with other pathways first. And often in people with ADHD, I do start with non-stimulants because there are real risks and concerns with the stimulants that aren't there with some of the other alternatives. So I'm not trying to second guess what the doctor's doing or saying, but I would say that part of their job is to explain why they are going with these options and what other options they think might be counter options. And I'm reading further parts of the question, is that Incognito also struggles most with motivation and finishing tasks. Strattera, atomoxetine theoretically can be of help there. And he or she also suffers from anhedonia as well, which classically antidepressants are the most effective. But there's been some research that anything that's promoting dopamine may be helpful with anhedonia. So again, it doesn't strike me as wildly inappropriate starting treatment. And again, what I would say is often, unfortunately, we don't have either behavioral markers or biological markers to indicate, or genetic markers, despite what some people claim and misinterpret, that strongly indicate, yes, you should take this medication, no, you should not take this medication. So often there is a trial and error aspect to finding the right medication or combination of medications. And usually that's based on what are the risks, what are the symptoms we're most interested in targeting, but side effect profile and potential risks are certainly a valid part of that. So Max says, hello, Merry Christmas. Do respected medical journals still have bad studies published? If so, how do these instances happen? Is it simply a mistake in the review process? So it's interesting. I'm trying to put together a talk and article on tyrosine, which is an amino acid, and ADHD. And there's very little research, and what the research I can find is 40 years old, done in the mid or late 1980s. On specifically ADHD, there's a much broader collection of studies looking at what are the effects of tyrosine in healthy people. But one of the studies I came across, and I think it was less than a decade old, was, I mean, it was there listed in PubMed, and then it was retracted. And I was trying to find out why it was retracted. And there's only sketchy, I mean, there was a note from the editorial board as they were re-evaluating it, saying that there were commercial interests. There were 4 authors on this paper. They were mostly from, I'd say, commercial psychological treatment centers pushing supplements for treating mental health conditions. So it said that there were financial interests that hadn't been properly disclosed, and that they felt that the consent and going through an ethics board for setting up the original study wasn't rigorously done. It actually didn't question the data or the outcomes. So how do bad studies happen? So I'd say there's 2 channels for bad studies. I mean, one is intentionally bad studies where people are manipulating data, altering results, padding statistics or numbers, so intentionally falsifying. And that can be hard to detect, depending on how skillfully they do it, and particularly if it's coming from a prestigious lab or center, sort of the more, that can be harder to detect. There've been some attempts to study, and it looks like intentional manipulation seems to be less than 10% of the bad or retracted studies out there. So more often, I mean, particularly if you're fooling with sets of numbers and computers, or even pre-computers, when it was also difficult, subjects can be entered in the wrong column, results can be registered the wrong way, subgroups can be dropped. There can be lots of sloppiness, that particularly if the result aligns with what the researcher wants and what the reviewers want, it's easier to overlook or not detect some of that. I don't know if carelessness is the best word. I'd say inadvertent errors. I don't know if that answered it. I mean, the other thing is that it's hard to study because it's hard to know what you are missing. So, and there's a few studies, again, suggesting that the vast majority is inadvertent rather than intentional. That's not even, I mean, maybe a greater percentage of the articles that are already out there are not accurate. So that if those were included, that might skew the results differently. So incognito, and again, I don't want to second guess. So the TOVA is a measure of variable attention. That's part of the title. So it's an objective attempt, but lots of different conditions can affect attention, not just ADD, ADHD. So a good part of any assessment is someone asking, is an in-depth, so every single group, whether it's the pediatric groups, whether it's the psychiatric groups, whether it's the research groups who focus on ADHD, say that the gold standard for a evaluation of ADHD is a clinical assessment by someone who knows what ADHD is. It's not any set of questions or a questionnaire. Interestingly, a paper just came out this week that one of the most widely used screening questionnaires, so it's not an in-depth evaluation for depression, the PH9, that's something like more than half the people who are so it's a self-administered question which is supposed to screen for depression, and it's widely used and it's been validated or found to correlate with actual clinical depression. But this study, and I have not read it in detail, so I'm not sure what percentage, but an extremely high, it was well above half the people taking this self-assessment were misinterpreting or misunderstanding the very questions or how to answer the questions. So it brings one level of why some of these questionnaires are not particularly useful or valid. So part of what the clinician should be doing is asking about when did these, if these symptoms only showed up after you got sick with COVID 2 years ago, that's different than if they go back to childhood. Are they present in different situations? Are there things that make them worse or better, which can either increase the likelihood that something other than ADHD is going on or that it's ADHD? Are there inconsistencies where you can attend certain classes or pay attention and are rapidly attentive, but all the others are, your mind is drifting through them? That would actually be consistent with ADHD, because consistently inconsistent is part of ADHD, but it's not there in terms of the 18 DSM symptoms or embedded in almost any of the questionnaires. So finding out the time course, finding out the context, trying to evaluate for other conditions like depression, anxiety, someone elderly, it might be dementia that could overlap or contribute to some of the same symptoms is important. My general recommendation for people is to contact, so CHAD, Children and Adults with ADHD, it's a patient-centered community or nationwide organization with chapters in virtually every major US city. So I would reach out to CHAD in the community nearest you. Again, that's CHADD, I think it's .org. And most of the local groups have referrals to providers in the community that do have some expertise in ADHD. So at least there you have some vetting and some awareness that the person didn't just, the provider didn't just check a box themselves on a questionnaire saying, yes, I have expertise in this. There's real live patient interactions with the provider that confirm they have some experience. So it's not that the questionnaires are bad or evil, it's just that they don't do a good job at ruling out. The other thing is, particularly with ADHD, many of the symptoms are, virtually all the symptoms are things that quote unquote normal people are doing many times. So it's the severity, the frequency, the extent to which it's impairing someone's life that leads to an ADHD diagnosis. And right now, in terms of laboratory testing or genetic testing, we don't, so the most informative on genetic testing is, and these are only being done on a research level. You could get a polygenome score, but that just tells you, are you in the quartile of the population most likely to have ADHD or least? And the difference between the two is something like 3 or 4-fold difference, but many people in the group that genetically is most predisposed for ADHD don't have it. And there's certainly many individuals, and there's certainly a few in the group that's least genetically predisposed to having it who do have it as well. I hope I said that right. So again, that genetic profile is only giving you relative likelihood, and there's still people in every genetic predisposition group who have it and some who don't. So Max is asking, do I think the conflict of interest between the APA and the revenue they get from the DSM-5 is problematic? Does it incentivize them to keep categorizing new conditions that may not need to be there? So my understanding is that the DSM and versions of it and descriptors from it and diagnostic manuals based on it are a major source of income for the American Psychiatric Association. Is that necessarily a conflict of interest? I mean, as long as they identify that it's a source of income, I think in one of my videos, at least I know in one of my Medium articles, I went, and it was actually the one about Trump derangement syndrome. I go into part of the process. So it's not that there's some high-paid psychiatrist who's getting tipped off by the OCD lobby to include a variant of OCD in the DSM. So one is including anything in the DSM is a long process. There's panels that are proposed to study it. There's separate panels supposedly to independently review whether this makes sense. There's supposed to be a collection of multiple studies done multiple places to validate that whatever is being looked at is an actual condition. So it's a very long, slow process and not a very efficient one for generating money. And I don't know, I mean, we can look at the drug company aspect to it, but just having your condition in DSM or not, I mean, people use terms widely like malignant narcissism. That's not an official diagnosis or term. It's widespread. It not being an official term, or Trump derangement syndrome is being widely used. So I'm not sure that inclusion or exclusion from the DSM in most research or other settings has that big an impact. So where it has an impact potentially is with insurers. Some insurance companies require having a diagnosis or that you are evaluating for a diagnosis. But again, a doctor can, there's so many standard diagnoses that may be close to what the person already has. And again, usually technically, you're not saying that the person has this, it's that you are evaluating it potentially to rule it out as well. So having a diagnosis associated with the visit, again, I don't see, so I guess the biggest potential area where finances come in is if a company is developing a drug for a problem that is not yet recognized as an official condition. And again, to get FDA approval, FDA only approves drugs for treating specific conditions. So there might be pressure there. But again, the process for getting a new diagnosis is 10, 20, depending on the amount of data, 10, 15 years, even though revisions are coming out every 3, 4, 5 years. So it doesn't seem to me a very efficient or rapid way of exploiting the system, but maybe I'll stop there. So Dennis, hi Dennis, should everyone aged 35 and older get a neurologic exam to check for cognitive decline? So it's a good question. And I'll be a little fussy about terminology, which is not that strange for me. So a neurologic exam is usually taken to mean an evaluation by a neurologist who is measuring rapid alternating finger movements and hand-eye coordination and balance and sensitivity and reflexes. So a neuropsychiatric condition, and usually is fairly devoid of much cognitive investigation, or may throw on either the MoCA, which is the Montreal Cognitive Assessment Test, or the Mini Mental Status Evaluation Test, both of which are 30-question exams meant to be delivered in about 10 minutes, which are screening tools. So although a certain president of the United States has repeatedly boasted, both more than 5 years ago and recently, that he's aced the test and nobody else ever does that, most normal humans get a perfect or close to perfect score on that. So they're not particularly sensitive. Why they're used as screening tools is if they detect something is off, then it is definitely worth exploring or evaluating that more. So a neuropsychiatric evaluation, or a neuromemory, psychological memory evaluation, should entail much more extensive evaluation of memory, working memory, reaction time, processing speed, attention, sustained attention, impulse control, a broader range of cognitive and executive functions. So one question is, so part of it is there's a great deal of human diversity, both in terms of our genetic inherent abilities and in terms of our lifetime experiences, educational opportunities, that affect how someone will perform on any of these tests, as well as variability due to if you had a cold that day, if you're just learned your brother got hurt in a car accident and you're distracted. I mean, so performance on any one test on any one day, there's a lot of variability packed into that, but particularly regarding the tests are skewed towards a norm. And if you're smarter than that or more educated than the average person, it's hard to detect. You had to be more impaired from your baseline than an average person would be for something to show up. So getting testing like this is useful for establishing what your baseline is. The other thing about neuropsychiatric testing is that it's supposedly standardized, and supposedly if you take the same test in different locations, you'll get the same exact results in scoring. But I've seen enough of it that there are sometimes subtle and sometimes blatant extents to which, so a common one is, I don't know what right now off the top of the head, whether it's the MoCA or the other, that part of it is asking you, do you know where you are right now? Do you know what city you're in? Do you know what county you're in? And I've been to locations where, someone travels for a test, and I've seen the investigator say, oh, well, it's okay that you don't know that, because we'll give you full credit for it anyway, because you've sort of explained you knew where you were. But technically, in the validation process was knowing the answer to that specific question for where you are taking the test. So essentially, and the other one that I see all the time in testing, in which clearly I talked about it in the screening for Trump, and I'm going to mess up the exact words, but he recited the 5 words that he was told, and he remembered perfectly, which was man, woman, camera, TV, person. And if someone administered the test and gave him those questions, the test is completely invalid, because the whole point of those 5 words is that they're not immediately associated with each other in most people's minds, and therefore they're harder because they're independently, randomly chosen words to. So I mean, with his list, if you get one, it's easy to bring up the whole screen with the randomly chosen words. Now, the problem with the words that are designated is that if you have repeated testing, you may remember the same words more easily than if you were only asked them once. So where am I going with that? So so even though the testing is standardized and you should get the same results everywhere, they're not perfect. So yes, I think there's value to getting a baseline. At what age it's reasonable. Again, looking at the studies on normal aging, again, which may include some people with early dementia, but looking at the connectosome study showing patterns of connectivity in the brain, they do suggest that starting in the very early 30s or late 20s, brain structure is changing and many executive function tests are beginning to decline and continue to decline over the next few decades. Again, it's a slow decline. It's not as abrupt or noticeable as with dementia. So yes, I'd say there's a value to it. There's certainly these are usually several $100s in the US or a few thousand if you get 3 hours of testing on different days. Some of this is being increasingly computerized and could be self-done. That should lower costs. Whether it will lower costs in the real world, harder to know. Um, so I can say more there. Again, so the other thing my Medium editor likes to point out is that even among US citizens above 65, 90% of them do not have dementia. Now, how many of them have pre-dementia and will go on to dementia if they live long enough is a different question. But the other issue is how, at a societal level, there's a cost to spending time and resources and money testing everyone. Is dementia common enough, or can we do enough about it beyond most of the most effective, I want to even say the strongest correlations in terms of slower declines are all lifestyle factors, exercising more, keeping your brain intellectually active and socially active. So Max asks, have you ever worried that by specializing in ADHD, you may have some confirmation bias with patients, thereby seeing predominantly ADHD when it could be something else? So yes, I mean, it's a possibility I'm aware of. I mean, and I think I know enough about, even though I've specialized in ADHD, I haven't run an ADHD clinic. I have almost half the people I work with don't have ADHD, at least that I can detect. So I've worked with depression and panic and social anxiety and PTSD certainly, and it's unavoidable to have substance abuse disorders in there and personality disorders. So I think I'm a little more this sounds snotty or conceited or grandiose, but I'll say it, that I think I'm more careful, I'm more detailed, I'm less invested. I mean, whether you have ADHD or not doesn't give me bonus points or not. Um, I mean, there's enough of it. There's more than enough to be treated out there. So I don't think I have a particular investment in it. And the other thing is there's patients I've worked with, even some for many years, who I think now probably have it, who I did not detect earlier on. I mean, particularly high functioning, intelligent individuals who we focused on panic or depression or other issues that can interact with ADHD, but part of particularly working with them over decades and seeing the trajectory of their life and how that on either relationship or work levels was thwarted, and that they weren't depressed or anxious during most of that time, and other traits so I guess one way of reframing the question is, am I overdiagnosing it or underdiagnosing it? And I think certainly I can do both, but I think I keep fairly rigorous standards to have. So I've had people come in who were convinced they had ADHD that I did not think that was what was going on. And I treated them for what I felt was going on and explained what I was doing and why I thought that helped and why other medications were not appropriate. So, but I am certainly not perfect, so I'll end it on that. Sean asks, does needing multiple doses suggest I have rapid neurotransmitter reuptake and that reuptake inhibiting non-stimulants might provide better baseline coverage? Therapy so one clarification is that the stimulants are reuptake inhibitors. So Ritalin particularly, that's almost all, or according to some studies, all of what it's doing is norepinephrine and dopamine reuptake. Amphetamine products are having additional release from synaptic vesicles to add of dopamine and norepinephrine. So needing multiple doses doesn't suggest that you have a rapid. So the neurotransmitter reuptake is something that happens on the order of fractions of a second usually, or a few seconds. So neurotransmitter released from one cell, diffuses across the tiny, tiny space, synaptic space, binds to receptors on the receiving end, but also is in equilibrium, binding and unbinding from the receptors there, diffusing into the synaptic cleft, rebinding to reuptake receptors, transporters on the cell that released it, and getting taken back up. So at a neurochemical level, it's more likely, or what's usually termed a rapid processor, that's not the word, I'm blanking on the term, is that the neurochemical, that the enzymes in the liver that break down these drugs are just breaking down the drugs much more quickly, so that your blood level of amphetamine is dropping more rapidly because enzymes are inactivating it more rapidly than the average person. That's, I'd say, the default presumption. There certainly could be other explanations. User HY6, I'm not going to end, was the one asking on Reddit about ADHD and autism. I was asking in general about severe autism and ADHD together. In that case, does it make sense to treat ADHD? Autism would be the bigger problem. So my bias there, again, without knowing more, is that we have thousands of studies showing that most ADHD symptoms can at least be partially treated by medications. The medications have a large size impact on symptoms. They have a significant role in improving life functioning. They work in the setting of ADHD with autism. On the other hand, in terms of treatment for autism, and we're beginning to make some progress, we have very limited data for medications or other treatments having major impact on the symptoms. So just in terms of, we have some part of what's going on here potentially that can be treated, even if it's not the biggest element of the problem, it's the most treatable part of the problem, at least by current awareness and treatment availability and what's been well documented. So my comment there is that, yes, it makes sense to treat the ADHD because we have fairly good tools for that. And thanks for the suggestion. I have plenty of suggestions for talks, but I'm always open to new ones. So yeah, so addressing the use of ADHD medications in the setting of autism would be something that applies to lots of people. So I'm still open for 10 more minutes. Looks like there's, I don't know if all 7 of you watching right now have thrown in questions, but you're welcome to. Again, I will not be here next week. I will be back in 2 weeks. And thanks, Max, for filling the gap. Max asks, what do my colleagues, friends, family think about your YouTube channel? Are they supportive of it? Do your kids brag about having an influencer dad? I'm not good at self-promotion. So in my Christmas card this year, I did include that earlier this year I was on the Huberman podcast, and that a third of a million people have seen that 2+ hours on ADHD. And I had a couple friends who've gotten back to me now saying, oh, pay attention to Huberman. I hadn't noticed that you were on. So my twins are recent college graduates, or half a year out. I think they find it mildly amusing when or if their friends find out that I'm there. Maybe things will change. So my second book, the rough draft, was submitted to the publishers a week ago. There'll be proofreading. It won't be out till mid next year. It's called ADHD World. So maybe it's about how ADHD forces in the whole world. It's not just computerization, but increasing temperatures, poorer sleep, poorer exercise, diet, a whole host of factors, probably plastic in our world, is pushing all of our brains to have decrements in executive functions and social factors like loneliness and viral factors like post-COVID. So it's about ADHD in a broader sense. Maybe that will generate more attention and I'll be a real influencer. I don't know. So user H16 asks, is there a relationship between epilepsy and autism? And I know that there is a statistical, if you have autism, you are more likely than the general population of epilepsy, and I believe the other direction as well. And I think most people would say that it's probably a third factor that's confounding or contributing to both the development of epilepsy and autism that's at play, rather than one causing the other per se. So thanks. I hope Max is listening. Max has been helping me for the past over a year with the sound, and much more broadly than editing the sound, but that's the central piece he started with. So yes, I have multiple interviews. Probably should be added to the playlist. So I'm glad it's helpful. I'm glad that you're getting something out of it. I do think there's potential for many, many more people to get something out of it, but I also am aware I get fairly regular feedback that the monotone, the slow pace, the too much detailed information doesn't play to an ADHD audience. I mean, my feeling is that there's been enthusiastic support and valid evidence that people have benefited. So I don't know, maybe I'm only appealing to a very narrow niche of the ADHD world. Who knows? User HI6 feels like the hyperactive ADHD symptoms are only present when I'm drunk and or use too much internet. So I feel I have inattentive ADHD only. The hyperactive symptoms just don't happen naturally. So, and I'm not commenting on your individual situation, but that's in my video on inattentive ADHD, I sort of mockingly question whether it exists or not. And it's, maybe I shouldn't pick on the same example, but the example I picked on there was a woman who's prominent in the ADHD world. She's done great work making ADHD more awareness that ADHD exists in women, more awareness of ADHD exists across a lifetime. And for most of her life in the ADHD world framed it that she has inattentive ADHD. She wrote a memoir where she described numerous incidents, which I would say are classically not inattentive, but they're hyperactive, impulsive. I think one was going out and kayaking on Puget Sound Bay, other things and climbing up on big counters and having a fall or a near fall when she was a little kid. There seems to be a lot of stigma still about hyperactive symptoms and lots of either denial is a loaded term, but either unawareness that the person's displaying them or unwillingness to acknowledge them if they're there. So I see many more people I would categorize as mixed rather than certainly purely hyperactive is unusual, but I think lots of people who classify themselves as inattentive only, to me, do seem to fit on a profile of combined traits, and particularly some of the traits that I see. Again, ADHD symptoms were written and defined in terms of children, and several of them, like unable to sit still, although we see a certain president who gets up and walks around during press conferences or group photo meetings, but in general, the hyperactivity of adults is more muted, but particularly poor regulation of volume. I mentioned a person in my social circle who would have conversations at quiet restaurants at empty in the middle of the day because lunches tend to drag on 3 hours, and would start talking louder and louder, particularly at emotionally loaded topics. But the things that were most embarrassing to this person were the ones that they were almost shouting with no awareness that they were shouting, and loud enough that people from other tables were turning around to look. And again, this was not intentional. This wasn't just anger either, which anger promotes talking more loudly. So I've just seen a lot of individuals who weren't aware of aspects of hyperactivity, which I think I was detecting. So yeah, so and users bringing up again the autism, ADHD, and making the statement that people with autism, when they make investigations, they go deep, they learn a lot of things in theory, but then have problems applying that information in practice, so it feels that they don't know much. Yeah, I think that's almost, I mean, when someone who has memorized all the train tables, I don't think most people's assessment is that person doesn't know much. It's that they know a lot about something that is disconnected from most people's reality or to usefulness. Um, yeah, so again, I don't see the claim of. So Incognito asked, do I do ADHD assessments? So I moved from San Francisco to Hawaii 3 years ago, August of 23 and a half years ago now. And for years, during the Trump administration, during COVID, I was extremely busy. I'm oversharing, but that's okay, unless you want me to stop. I did not work like most psychiatrists or therapists. So I had the ability to work, from 7:38 in the morning till 4 or 5. Maybe I'd take a break for lunch, maybe not, but see patients back to back to back to back and be able to switch focus and be completely attentive to the patient. Anyway, I was working a lot and partly working probably more than I is ideal or healthful, and had great inability to say no to people, even though my voicemail for years said I'm not taking new patients. That screened out some people, but it didn't screen out everyone. And since moving to Hawaii, I've been completely consistent about being able to stick with not taking any new evaluations, not doing consultations. Part of it is so that I can spend more time writing and talking, because I think I have information that can, I mean, my thought of my role in life, or why I'm here, was to help a few people a lot and to help a larger number of people a small amount. And that by writing in the video information, hopefully I can reach a lot of people and help a little bit, but knowing that it's not a big help. Or maybe I shouldn't say it that way. So thanks for showing up. Thanks, Max, for helping out. Hopefully the world will be slightly more sane in 2026, and I will see you in the new year.